afternoon and welcome to today's webinar, Is Voluntary Assisted Dying, or VAD, the solution to end-of-life care? I'm Kelly Higgins-Devine. I'm your facilitator for this afternoon. I'm a presenter on ABC Radio Brisbane. I'd like to acknowledge the traditional owners and their custodianship of the lands on which we meet today and pay my respect to their ancestors and their descendants. We recognise their valuable contributions to Australian and global society. The panel discussion today, hosted by the University of Queensland's Centre for the Business and Economics of Health, will unpack the important question, is voluntary assisted dying the solution to end-of-life care? As many of you will know, Queensland recently joined 5 other states in Australia to pass a bill that legalises voluntary assisted dying, due to come into effect in 2023. And we'll be using their acronym VAD throughout this discussion. Between now and then, we expect there'll be much discussion among the health business, insurance sectors as to what that might actually look like. Today, we will endeavour to unpack what VAD is, to talk about the current failings in end-of-life care, the economic impact of the two, and what might be some key discussions and considerations that come into play in the next 12 months. And while based in Queensland, the context in which we'll discuss these topics today are not limited to Queensland and are applicable at the top level for all governments who might be exercising this same legislation. So let me introduce you to your speakers for this afternoon. Joining us from the Centre for Business and Economics of Health, or CBEH for short, is Professor Brenda Gannon and Associate Professor Haitham Tuffaha. And Brendan and Haitham are health economists who are experts in applying their business and economics understanding to contemporary health system problems in order to mediate solutions with sustainable answers. And these might typically include, but of course not limited to, issues of access and equity, funding and cost effectiveness, policy and inefficiencies. They have 20 years combined experience in economic modelling as it pertains to the health sector specifically, and their work influences both organisations and policies to become more equitable and efficient for society at large. Brenda is currently an affiliate member of the ARC Centre for Research Excellence in Population Ageing Research and has won over $28 million as Chief Investigator in Collaborative Research Income. She's worked extensively on interdisciplinary research with gerontologists, clinicians and methodologists, and her work has been influential in the development of many programs and informing policy. Haitham is the chair of the Clinical Oncology Society of Australia's COSA Epidemiology Group and the co-chair of Australian Clinical Trials Alliance, or ACTA, Research Prioritisation Group. His research involves the economic evaluation of health interventions. He holds a Masters of Science degree in clinical pharmacy from Strathclyde University in Glasgow, an MBA degree from Wollongong University, and a PhD in health economics from Griffith University. Before specialising in health economics, Haitham practised as oncology clinical pharmacy specialist and manager. And joining them on the panel, we have Emeritus Professor Geoff Mitchell, MD. Dr. Mitchell is a clinician and an expert in understanding the nuances of VAD and palliative care at the patient and clinician level, including impacts for doctors, nurses and other medical professionals in this area. He's a Professor of General Practice and Palliative Care and was the inaugural Director of the Centre for Palliative Care Research and Education. Geoff continues to play a role at UQ in research and mentoring. He's also a partner at Limestone Medical Centre in Ipswich. So welcome all of you to the panel today. I'd like to kick off the conversation with Brenda. Why is economics, and specifically the combination of a health economics perspective, important for topics such as this one?
Oh, thank you. Yes, so every day we make decisions about our health and economics and trying to make the optimal decision with respect to what kind of healthcare we might get. And so where health economics can come into that, and a lot of the work that is done at the Centre for Business and Economics of Health surrounds issues in health economics, working together with clinicians, gerontologists, collaborators across health sciences, across the community, consumers, end users as well. And so the four main things I would think about in terms of what is health economics really? What we want to do is address issues about efficiency, how much output, how many people's lives saved can we have per input, such as resources used. Equity, making sure any treatments are equitable across society, making sure people can actually afford to have them and are open if they have a healthcare need. But on top of that, of course, any of the treatments have to be effective, so efficacy is important. And then finally, ethically as well, which I think is where we're going to touch on today. So with those concepts, we can actually address a lot of issues. And this one here today is quite unique in that across the world, there has been some discussion about VAD and the health economic aspects, but I think it's actually still quite under-researched. So it's really great that we're having this discussion now. And we can highlight, how health economics researchers working together with others can come to solutions for this as well.
Well, let's talk about the current end-of-life care landscape. And Geoff Mitchell, if I could get you to define VAD, palliative care, and end-of-life care, and how they interrelate.
Thank you. So VAD is short for Voluntary Assisted Dying, and it is a legal mechanism now that allows people to make the choice to end their own life when they believe that the level of suffering that they are enduring is unbearable. They also have to be of sound mind, and they must have a prognosis of 12 months or less. Palliative care, so the intent is to end your life, to end your suffering. Palliative care aims to make the last weeks, months and days of your life as productive and useful as possible, to provide the greatest level of quality of life and to control the symptoms that would cause difficulty. And the medications and the treatments that are undertaken look at the patient and their family, and they also do not intend to shorten life but to allow nature to take its course. End-of-life care generally refers to just the last few days, when there's often a very rapid deterioration from struggling but going okay to death is clearly going to occur, and there's specific signs that tell you that that's going to happen. The treatment then becomes more intensively around comfort, and also to support the nearest friends and relatives of that person.
Well, let's talk about some of the misconceptions of VAD then. And first, that access is for anyone who no longer wants to live.
Well, the law is very clear that it is not for everyone. So those limitations that I mentioned before, you must have unbearable suffering in your perspective. You've got to have a prognosis of 12 months or less, and you've got to be have legal capacity to make the decision. Legal capacity means you can't be demented, and most people who die in their very old age have some degree of dementia. So many people will not have access to VAD. Prognosis is very difficult to determine, and it is only really possible in cases with a very clear trajectory of illness. So cancer and some of the neurological conditions have a prognosis or a disease course which allows you to make that kind of judgment. And 12 months is a long time to be guessing what's going to happen. So the other group that is not included in all of this is people who accumulate many diseases as they get older. And the burden of those diseases eventually becomes so great that life is not going to be sustainable. And they won't fit either because their prognosis is very, very uncertain.
What about children, for example, who may have terminal conditions?
You've got to be over 18 for the law, so no.
So they're ruled out as well.
They're ruled out.
How common do you find those misconceptions with people that you speak to about VAD?
Not so much those. They haven't come up that much, but what is very often misunderstood is the difference between deliberately ending life by an act and withdrawing treatments that is actually prolonging your death. So, for example, if you're having artificial nutrition and hydration, or you're having chemotherapy with the intent of trying to extend your life, and you come to the point where you realise that the disease is not going to be extended, it will progress no matter what, then withdrawing that treatment may shorten the person's life, but it's not because of an act, a positive act, it's because you're getting out of the way of the natural process. It's a very important distinction to make.
I think also, you know, in addition to that, there's a misconception about, you know, the cost of it and that it's a cost-saving exercise, and so there's still a lot of misunderstandings around. So these discussions are great, and in fact, actually, when it went to Parliament, I think that may have been missing from the agenda in the economic consequences. I know some people did talk about it, but it's not exactly a cost-saving exercise in that uncertainty is there. We don't really know what healthcare resources people may use, and so for people to make decisions, and this is where the economics can come in, is to be able to make an optimal decision, is to be able to weigh up those costs and benefits in terms of valuation of your life, and also valuation considering burden to financial burden, and really, you know, in some of the literature it says that it's not just about financial saving, it's more of a quality of life. They want to, people want to reduce burden on their own family. So bringing in a societal perspective into the cost evaluation is quite important. So a narrow perspective just on a healthcare perspective can limit that to some extent. So in any economic evaluation going forward, that would have to be brought into it. And I think that's a misconception, that health economics is just about its cost savings, but in fact we need to make sure something is effective as well. So that is a misconception, yeah.
Do you find that people are uncomfortable having a discussion about economics when we're talking about the end of somebody's life, and that is why these discussions can come either later or maybe even not at all?
Yes, totally agree with that. And what we do is not about just cost saving or avoiding cost of financial. Everything needs to be patient-centered, and patient preferences should be taken on board. Now, I think many people find it difficult to discuss things around the economics of the process, etc. But we live in this society, and we know that we have limited budgets, and we need to make sure that we provide equitable care to everyone by allocating funds wisely and having an efficient system. So when we say we want to have an efficient system, this doesn't mean that we want to direct resources from one group to other, but we want to achieve equity among all groups, so everyone will get what they need at the end of the day, but maintaining, having sustainability and maintaining an efficient system.
Geoff, why aren't patients getting the best end-of-life care that they can be?
Well, many are. I'll start with that, but it really depends where you live and what you suffer from. We have among the best palliative care services in the whole world. It was ranked number 2 by a survey by The Economist, actually, some years ago, and we were just pipped by the UK. But because we're a big country, we're decentralised, the provision of this really expert palliative care network is necessarily patchy. So rural and remote people, there are people who are in certain societal groups that have difficulty accessing it, so Aboriginal and Torres Strait Islanders, and people whose English is the second language very often don't know how to access it, and therefore miss out on what's available. And then the type of diseases have a big bearing on it. If you look at the population of palliative care units, just over 80% of those are comprised of patients with cancer. If you're over 70, which is when most people die, the proportion of people who die of cancer is 19%. So do the maths.
Yeah.
And who looks after everyone else? So it depends very much on the skill of the people who aren't specialists as to how effective end-of-life care is.
So does that leave the majority of the care then for end-of-life to nursing homes where people may be, and that's where the care is being administered?
Very substantial proportion, not all, because there are other people like people with advanced heart failure or lung disease who are getting their care in tertiary hospitals, for example. But yes, a very large proportion of people will end up in aged care, the multimorbid, the dementing patients, and they are cared for by the nursing staff, personal carers and the like in aged care facilities. And the medical support is by general practitioners, by and large.
Haitham, what about the administration or continuing to administer medicine or help beyond what that person really requires?
Yeah, I mean, this is an important topic, and we started to refer to this as we call low-value care or futile care. So what it means is that you offer care that doesn't improve the health or doesn't improve quality of life, and sometimes it comes at an extra cost and may cause harm sometimes to patients. So it's like over-treating them, and it's a common, I would say, practice in certain places, especially at the end of life. And a literature review of like 35 studies across the world, 1 in 3 people, adult people receiving end-of-life care, received unnecessary care. And 10% of the cases admitted to the ICU when there was no need for admission to the ICU. Procedures do not include it's not just about medicines, but we are talking about investigations that are not necessary, tests that are necessary, some aggressive sorts of treatments as well, including dialysis, etc. So this is a common problem.
Well, this is an issue for the future as well, isn't it? Brenda, if I can go to you, you've got an ageing population, and VAD is only going to be, as Geoff outlined, available to a very small percentage of people. So how do we look at this issue going forward?
Well, I think that the ageing population is another interesting concept or misconception even. A lot of the time the discussion is surrounding the ageing population and the expense of treating them. Whereas in fact, as we know from across the board, it's end of life is the expensive part, and particularly in the last few months, and even as you said, the last few days. And so therefore blaming the older people as such for the burgeoning health system is a bit problematic, I think, in terms of the terminology. However, we are facing a demographic shift. So there are many, many more older people, and hence, yes, there will be a burden on the health system. Given the fact that many are not eligible based on the criteria, then there will lead, if that is a person's wish, but they're not allowed to avail of VAD, then there should be in place other good palliative care, and really about pain management, I guess, in the suffering a person can entail in the end of life. Again, that is, comes back to Haitham talking about over-subscribing and over-prescribing and pain management. How much does it cost? And the question I think it comes back to in the economics in terms of the ageing population is who's going to actually pay. So is it the person themselves? Is it the public health system? Or is it private insurance? And then hence it's only available to a higher socioeconomic group. If it's the public system, then we have to consider our own willingness to pay towards a tax, incentive, or towards like a Medicare levy. How are we going to fund this into the future? This comes down to discussions about long-term care as well. But in fact, actually, there was a study done before about people's willingness to pay for via VAD and also end-of-life care. And one of the questions in the study was about if there was further investment in good research and development in terms of proper pain management that could alleviate their stress and suffering at end of life, then people would be less willing to pay. So there's an interesting debate going on there, I think, across the whole economy really, and And also it comes down to opportunity cost, which is another one of my favourite words in economics, and alongside efficiency and equity. And with that, as Haitham said, if we have pay for one system, then something else has to suffer. So it's the trade-off between the two, and then I think it's down to us as public people to decide what we want as consumers going forward, and hence the involvement, as I said at the start, about having consumers in on these debates as well, patients, end of life, family, carers, all that.
Geoff, has there been much discussion in the past or even now with the very people who are going to be accessing these services in the near future, or families who've gone through this, about what was helpful and what wasn't?
Probably quite a bit of informal discussion. I'm not aware of too much formal discussion, except when the legislation was there was calls for submissions, and there were many submissions from people who felt strongly one way or the other about it. Personally, I have had only one request in 37 years. And I think that's very interesting. I get a lot of people who say, I wish this was over, but I've only had one person said, do it for me. And what makes people wish that it was over was that that life was being burdensome, both for themselves and also for their family. They didn't want to be a burden. And so a lot of the attention that we pay in end-of-life care and palliative care is around minimising burden, taking the burden off the carers, and because they carry most of it. Listening to them and trying to address their concerns and their needs so that they can actually, and respite, all of those things can sort of relieve the burden and help them to keep going.
Yeah. So, Haitham, if I can go to you, what does end-of-life care cost?
Oh, that's an excellent question. Previous studies estimated that it costs around $5.5 billion a year in direct cost to the Australian government. An updated report last year estimated this to be around $8 billion that we pay every year. And these are direct costs to the government for the care provided at the end of life. However, we need to remember that there is burden and spillover over that for the family. So there is out-of-pocket expenses that are covered by the patient and their carers. There is also indirect costs for the carers who maybe take time off their jobs to care for their loved ones. And this means that we have productivity losses, and that would affect the economy at large. A main driver for this cost, I would say, is the majority, like it's 50% of this happen at hospitals, 35% happens at residential home care facilities, and only 10 to 15% will happen outside these settings, like at home. And costs in hospitals and aged care facilities are really high, and they drive the total cost to the system.
So, just a couple of things. That was a national annual figure for care at the end of life for everyone. Is it possible to tease out the cost of low value care versus non-low value care? And is it possible to look at the issue of what I would call a near-miss home death, where 98% of the care is taken place at home, but it just gets too hard right at the very end, and a person might enter a hospital or palliative care service just for a few days. I would call that a success.
Yeah, no, that's an excellent question. So regarding low value care and how to estimate its opportunity cost of that, or the cost of having low value care is important. So one study in Australia quantified that, tried to look at that, and it was a study looking at 3 hospitals, major hospitals, and looking at low value practices, and around 12% of the patients received sort of a low value care, and it was estimated to cost around 150, if you scale this up to the national level, it's $150 million, that 12%. And this was driven by 40,000 unnecessary hospital beds. So the difficulty is how to quantify that, because you need you need to define first what low value care is, and what is considered acceptable, what's not of value. So that's the first thing, and then you quantify that and place the dollar value. But this is one area that we need more research into, and we need to find a sort of more information so we could quantify that. But before we deliver low value care, I think it's important to invest in value care in the first place. So instead of being reactive, we need to be more proactive, design programs, redesign our system to deliver value rather than chasing up low value care practice.
Yeah. Well, I just want to go to government funding. What does it look like now, and what are the plans for the future? Like, is there enough money? Is there going to be enough money going forward?
Well, there's always not enough money.
You can always have more.
want to have more.
Yeah.
I think the question is, we do have one of the best systems in the world in terms of health system. We do have excellent palliative care services. The question is how to make the best use of those resources, how to use them efficiently. Just to let you know, for example, we have on the medical services, MBS, the medical benefits schedule, we have a number of palliative care services, especially those for the community. Out of those subsidized services, the utilization is only 10% right now. So last year there were 17,000 patients benefiting out of 160,000 deaths. So this means around 10%. So there's lack of awareness of the availability of those services. It's not. So I would say they are underutilized. They are there, but they are underutilized.
I think that's quite common across the world, actually, a lack of information. But I would also be concerned into the future, and I think it needs to be monitored closely, is the out-of-pocket cost, so the gap on top of the Medicare fee or the PBS fee for the actual prescription. There will be, there's suppliers of the service, and no doubt, might try to make a profit, or maybe, every supplier might have a different fee, and depending on where you live in the country, that could be different. So that out of pocket can become quite huge, and even for people with health insurance, who might think they're funding themselves, they still have those out of pocket concerns. So I think that's where the ethics comes into it as well, and I think that's something that the out of pocket cost is important to monitor. Not just if the people are having palliative care, but VAD as well. Yeah.
So how can we use cost effectiveness analysis to improve this for society and patients?
Yeah, so when we say cost effectiveness analysis, we are talking about comparing the cost and effects of alternatives. And as Brenda said, we need to make choices, and we need to consider the opportunity cost. So one way Australia is leading actually in this field, where we look at the value for money of different healthcare services and interventions. So economic evaluations or cost effectiveness analysis are instrumental in informing policy, telling us which services we need to invest in. And so far we have good evidence, for example, about palliative care, especially the ones that's delivered at home or in the community, that the majority of the evaluations showed that it's cost effective actually to deliver these. Another example is that we unfortunately have mixed results when it comes to palliative care delivered in hospitals, and I think the main issue behind it is that maybe we need to improve the way we do those economic evaluations or cost effectiveness analysis to capture exactly what we need to capture in terms of all these costs, and taking a societal perspective, so the costs also to carers and the economy at large, and also to look at the value. What are these? What value elements we're talking about? Because it's not just about extending life or improving quality of life, but there are other things that needs to be captured and benefits that we need to include in the equation when we compare cost and effects.
Yeah, Brenda, when we first started this conversation, you mentioned equity in VAD as one of the sort of the core issues of it. What should be considered then when we talk about equity?
I think from a health economics viewpoint, equity is about access to services based on need. So assuming a person has a need and then their desire is to avail of a service, it should be equitable in terms of access, and that should not matter based on your own ability to pay or where you live in the country. So for example, there's been discussions here about people in regions not having access to facilities they may need. And so that goes for any service, not just VAD. So I think that's where equity will come in, to make sure it's an equitable service. It's not enough just to have an efficient service and save lives or reduce pain and suffering. It has to be available to everybody. And I think that's where, in terms of resource allocation, equity is the hard nut to crack. It's hard. We can work to get effective measures, effective treatments, put them in place, reduce pain and suffering of people, but then to try and get it across the board for everybody is really hard.
Yeah.
And this is something that could have continuous research as well in terms of how to achieve that equity. But I have to say that at government level, equity discussions are included in the decision-making process, so that's good to see. And then on top of it, the ethical considerations. And if you don't mind, I'll just touch on that for a second. Not just ethical in terms of the patient, but also in terms of the provider. So there's also been discussions about some healthcare providers not happy with the current legislation. And that may have repercussions for the health system down the way in terms of workforce planning, and if workforce are not happy with decisions of a person receiving VAD on their premises. So I think that's something that is potentially needs further discussion over the coming months before implementation in 2023.
So it's that navigating of ethical matters while we're considering the economic matters as well.
Exactly. So that's why I continuously say health economics is not just about cost saving or even cost benefit or benefit of quality of life. It also has to include ethics and efficacy, of course. Yeah.
Yep. What about supply and demand?
Yes, that's another interesting economics term. So hopefully everybody is familiar with supply of service and demand for service.
Sounds so blunt in the sort of the frame of this conversation, doesn't it? Supply.
Well, it does,
and
but that's what makes health economics so interesting. We can apply it to any topic, literally, including something so sensitive as a subject today. And when I was asked by UQ to put forward when I was interviewed for the article that recently in UQ Contact, I was asked more about the legal framework, but I said, well, what about the economics? And it hadn't been thought about. So I started to talk about demand and supply, and we demand a health service, the suppliers supply it. In a normal economy, then that would be it. However, in healthcare, it's quite different, because we have a notion of misinformation, lack of information between patients and doctors, and hence we might have what's called a market failure and not be able to get the right quantity out there in terms of resource allocation. So what is fearful sometimes is a concept called supplier-induced demand, whereby if a physician can provide a certain service and can even profit, or it believes in it even. It doesn't even have to be about profiteering, it could be about a belief. And there was a study on this done in the US actually that showed variation in clinical care. Around 12% of the differences across states was due to physician belief in them diverting from guidelines, in fact. So again, is that ethical? But it can happen. And I think that's important, that physicians can make decisions on the spot. We shouldn't be driven by guidelines too much. So I think that within VAD, if a service is available, does that mean everybody will then actually want to avail of it, or are they going to be induced into thinking this is something I'd never thought about before? So I think how we can solve that is through information sharing and shared decision making with patients and consumers, as you do. So I think there's an answer to the problem, but it is an issue. Yeah.
Geoff Mitchell, what are your thoughts on that, and supply and demand, and where the patient lies in that, and as Brenda has described, and the physician as well, when we're considering these questions?
Well, Brenda, you mentioned location, and that's always going to be an issue in Australia more than most other places in the world. The legislation requires that if you can't or choose not to undertake VAD on behalf of a patient, then you have to refer to someone who will, which means they'll have to travel, sometimes a long distance. So I'm not sure how this is going to play out. It's not something that can be done by telehealth. It's actually got to be physically given to you. So there's that aspect of it. The other thing is that as the population ages, we've kind of skirted around whether aged care facilities is part of this $8 billion end-of-life cost, and I'm not really sure whether it is. But let's assume that it is. We know from the Aged Care Royal Commission that the funding that is being put into aged care by the Commonwealth has been cut by both sides of Parliament for decades. And we're in a position now where it is, the quality is very patchy. Some are really excellent, many are good, and there are some that are quite poor. And the cost drives that. The supply of beds, the wages paid to aged care workers means that many people will get out of it as quickly as they can because the wages are so much lower than they can earn elsewhere. And we are right in the middle of a doubling of the people who are going to need it. So if we're like that now, to correct this is going to take a decade, and it's going to take a lot more money than the government's bringing in at the moment, at a time when we are cutting taxes.
Yeah, and it's not just money. More money is always good, but it's not actually the final answer, as you say, because it has to be correct allocation of that money. And I think really part of the issue, as you raised, is about workforce, and not just the salaries they get, but even in the training. I think there has been more investment into training of aged care workers now, but just even from a personal experience of somebody I knew myself who went down that field, left because they had to do so many volunteer hours over the weekend while they were also working in their own job. And they said it was not sustainable. And those people would be ideal people for the workforce in the future if they want to change career. But it's the current training needs to be rectified, and I agree it will take many years. But I think the workforce and relying on current status quo will not be sufficient.
We have shortage already in workforce. So Palliative Care Australia benchmark is 2 palliative care specialists. That's an example. Per 100,000 population. Currently, we're sitting at 1.2. That's 50% of what we need. That's for today. So if you look at if you forecast this at the future, so definitely we need more.
Can I go back to that? We're talking about low value care. What is that? We've talked about that burden of ineffective care to society at large, but economically, how would it help to actually be able to, in fiscal terms, to say that's actually low value care, and if we stop that, then there is more money for actually good value care.
Yeah.
And does that often come down to, that desperate desire that we get when somebody's near the end of their life to extend it as long as they can? Do emotions play a very large role in decisions that often, end up being fiscally ineffective?
Yes, I was talking to Geoff before we went online. So the first rule in medicine is do no harm. So if we need to strike this balance between we want to deliver something that helps the patient, so either extend their life, improve their quality of life. If what we are offering is resulting in harm, if it's resulting in an extra cost, so this means that we need to avoid this. We need to be proactive by planning our services to deliver the value, and also to look at existing services that we can avoid and eliminate, and by doing this we could direct those funds into more maybe beneficial or services that can deliver more value to the community and to the society.
Geoff, did you want to throw in on that, just on low value care and also what it means to make those decisions as well as a physician? Especially when you've got an emotive family, who wants mum or dad, whoever it might be, they don't want to see them go.
This is a huge issue from a medical perspective. Decisions basically are driven by the senior medical person looking after them. So the attitude of the senior medical person becomes critical. And there has been work done to look at how a patient's death affects people in different specialties. And while generalising somewhat, it's almost as if a patient enters a contract with the specialist, and the specialist feels obliged to do the best for that person with every tool that they have. The problem is that not every circumstance that arises is going to be suitable for the tool that that person has. So if you're a surgeon, it's a knife. If you're an oncologist, it's drugs, and so on. And really what you need is someone who has the authority to say, it's time to stop the drugs, it's time to not operate, it's time to start less intense care. The analogy in building a house, if you have a contractor who says it's now time for the electrician and it's not time for the plasterer, let the electrician do his work first and then we'll put the walls up. But if the electrician is running everything and the only thing he knows is electrical contracting, then the house is going to be built very inefficiently. And this happens in hospitals a lot because of the siloed nature of the care that's offered.
Just a reminder, if you have a question as you're enjoying the webinar this afternoon, then please just go to the Q&A section and put your question in, and we'll get to your questions shortly. With this, Brenda, thinking about, the politicians make the laws, the health system then has to enact them. What sort of money, what are the costs of training people to be able to interpret those laws properly and then to provide that service within, say, a public hospital setting? Do we even have those figures?
To hand, I don't have that figure at the top of my head. So I would put that down to information, learning, and then sharing out the information effectively. And I guess that's a training that would have to come in place over the next year to ensure people can make informed decisions. And so that's at an individual level. At a more societal level, before decisions can be made, I think it's important to ensure that there's good information and it's an evidence-based decision, if at all possible. So I think we're beyond evidence-based policy as such now. The policy is there, but it's evidence-based decisions, and so for that information is needed and training of workforce. But I do think there'll be a lot of, particularly for the older population, setback from workers in that space that may not want to be involved either for their own ethical reasons or the provider's reasons as well. So there's a lot of issues to address, I think, over the coming year, and the key point is information and good information. Yeah,
we've talked a lot about the ageing population, but VAD need not necessarily be an older person. It could be somebody, as you've mentioned, Geoff, somebody in their 30s, 20s, of whatever, with a cancer or a condition where they feel my end of life is near and I want to end it. So what sort of considerations do we have for that, for people who are not elderly at all, who are in the middle of their lives or would be seen to be in the middle of their lives?
Well, it gets back to prognosis. It depends on the disease, and it depends on location. So if, regardless of age, someone has a disease that is progressing at a predictable rate and is likely to end the person's life within 12 months, well then they legally can undertake VAD. So I don't see any particular difficulties comparing old and young. I guess I'm thinking more from a population perspective, that the numbers of people involved they're very small, and so from an equity perspective, if you're thinking like that, are the parameters the right parameters? Well, they are the ones we have, and I think they've been very carefully thought through. There would be significant difficulties if they got broadened, but the reality is that it's going to limit it to a number of people regardless of age.
Yeah. Well, based on our discussion today, it's clear that end-of-life support is inadequate at the moment, and given that access to VAD is not only down the line, we're talking 2023, but also accessible to only, as you've just mentioned, a small percentage of patients, VAD's not going to address the issue at large. So with this in mind, I just want to get your key messages that you'd like the audience to take away before we get to audience questions. So Brenda, if I can start with you, from a top-level system sector perspective, what would you like to say?
Thank you. Yeah, so for systems-driven perspective, it's important to look at both demand and supply side, the efficiency, equity arguments as well, and to include everybody in discussions, also the patients and the end consumers. I think that would be the key message in bringing together all disciplines so that we can have effective solution. Haitham,
once again, your perspective from that top-level system sector perspective.
Yeah, I think we need also further reforms to the system to improve, first of all, the awareness about the existence of those services, improve their efficiency by selecting the right services for the right patients. The other thing, we need to improve coordination of services, because most of the time patients don't get the benefit because we do have sort of fragmented services. Investing in the workforce to enable this is an important direction in the future, and always ensuring that we have a value-based healthcare.
And Geoff Mitchell, from an individual or clinician perspective?
I guess the main message is that VAD is one part of a very big puzzle, and we mustn't focus entirely on that when the rest of the puzzle needs so much attention. So palliative care, specialist palliative care, but the area I'm particularly interested in, generalist palliative care, the care of people by those who are not specialists, who are looking after the majority, really needs a lot of attention and a lot of encouragement for people to take it on. It's not that hard most of the time. And if done well, then the quality of the life is as good as your condition will allow you. First thing. And the second thing is access and training, and just the implementation. The challenges of getting this right are vast. Depending on where you are, each challenge is going to look different, and if it's going to be done properly and well, then it's going to have to be very carefully thought through, and the training and the systems very carefully put into place. And I know a lot of work's being taken place, but it's only 14 months away. Can it be done and have it reliable and effective in 14 months? I hope so, but I'm not sure.
The other thing is that at some point the vast majority of us are going to have to confront this, are going to have to be a part of either making an end-of-life decision for somebody else or ourselves. How do we improve community death literacy? You've all brought that up as a part of it, that people need to know how they're going to go about this, what the rules are, what their options are. But it seems to be something that we only want to get to when we absolutely have to. And by then you're making very rushed, very pressured decisions as well. So how do we improve that? Brenda, you've mentioned it a couple of times.
It's a difficult subject, and I guess that's where planning, what your choices are for end of life, what's the optimal choice, and weighing up your own concerns. And so that might come into it. I think also maybe prevention sometimes is better than cure. So as was mentioned about the health system, if we can go back a few steps and prevent long-term conditions, diseases, of course the uncertainty is there, but there is something certain that the end day will come. So any planning, make it more accessible to people. It's like the ageing taboo word sometimes, that people don't want to talk about ageing. So likewise across the board, people don't want to talk about end of life. So more discussions, make it more normalised, I guess.
But then we have that, if you asked me now, how do I feel about a certain, a state I might be in, I might go, oh, look, once it gets to that, just, whatever. But then I might get there and think, oh, actually, I'd like to fight a bit harder. Thanks very much. So we also have to take that into consideration.
Absolutely.
That it's easy to be blasé until it's actually you or someone you love in that condition.
Well, I think this is actually where more research can come in, believe it or not. We always say more research, but by having more research about end of life and people's preferences, and there are many studies across Australia, across the world, about people's preferences for home care, chemotherapy, etc., and their cost and their willingness to pay. The more of those studies that are done, and we're embarking on some of these at the moment as we speak, then the more information the public will have. And that's our job is in this, like we're doing today, get the message out that this is the research that's been done. You have to think about how much you're willing to pay for the future, whether it's in tax or insurance or out of pocket, and that just to take the burden maybe off, take responsibility for your own decisions rather than having the burden on the family, which is sometimes how people perceive it at their own end of life. They feel they're a burden, and that's another cost. It's not a money cost, but it's still a cost. So.
All right, let's get to some of your questions now for the panel. Bart has asked, under current legislation in Queensland, will healthcare workers be obliged to deliver VAD? Will individuals be able to versus whole institutions, or will hospitals and clinics be able to opt in or out to this service? Okay, so let's start with, obviously the question is there, who's going to do this and who is legally going to be able to do this? What do we know?
So my understanding is that legally it has to be a doctor. My understanding is that you are not obliged. In fact, if you have a moral position that prevents that, then you don't have to do it, but you do have to refer to someone who will. So the people who will do it will be self-selected. They will put their hand up for it, and then they'll undertake the training required to be able to do it effectively and well.
Will there be, the other follow-on question, will this affect funding for these people or organisations? So if, say there's a religious group who don't want to provide this for religious reasons, obviously, is there any indication that they'll be penalised for making that decision?
I'm aware that is a big concern, and I'm pretty certain that the government has guaranteed that won't happen. But I can't say for sure.
Yeah, I think that's a big fear of them, and I think they feel a bit left out of the discussions before this was implemented, and that's why it's hard to go back a step now. I think maybe they should have been involved more in having more grounded discussions and agreements on this, and because not only from their own beliefs, which is an issue, there's a fear of loss of funding, and then where do the people go? If the worst came to the worst and a hospital did have to close a ward, or where do actually people go? So it's the people who suffer in the end as well. So it's quite circular. So hopefully the next today's conversation will highlight this, and then this will be included more in discussions.
Yeah. Jared has highlighted that in Victoria, where VAD's been in place for a while, costs to patients are being fully covered by the government. He suggests this will be replicated in other states too. In this sense, if patients aren't being burdened with out-of-pocket costs, is there a larger picture we all need to be aware of? Haitham, anything that comes to mind for you on that question?
Well, I'm not very much clear about the larger picture. So is it other expenses other than the out-of-pocket expenses? Or
It doesn't kind of go into that, but if there are no out-of-pocket costs, the larger picture, whether that refers to say more people doing it because there is no cost. Therefore, to you personally, you take a VAD option.
Yeah.
Brenda?
I think, that was one issue I mentioned earlier, was just because it's there, will people avail? But with the cost, and they're saying it's covered by state, I would be careful there. I'm not convinced. There are always additional out-of-pocket costs and gaps. And so just at the moment, the medication may be covered, and I looked that up, and I think it's covered by PBS, cheap and a high-end cost. But what's also covered are psychology services. But beyond that, there's nothing covered as far as I know, unless it's done at a state level rather than more broadly. So I would read between the lines on the out-of-pocket costs.
Yeah. Did you want to throw in anything, Geoff, at this point?
Well, I think the implication of that question is quite clear that if VAD is a cheaper option than pushing on, will people elect to go the VAD route? I don't know. I personally, I think it depends where you live as to how much out-of-pocket cost you are asked to pay. Where I work, cost is a huge issue. We're very, very sensitive to it, and most people, when they reach end of life, will be bulk billed, so there will be no out-of-pocket costs in our area. Other areas, I know it's quite different.
From Anon, what are your views on the role of data monitoring and evaluation to inform policy decisions in end-of-life and palliative care? And where do you think Australia is at as a nation on data in this sector?
Yeah, I think that's a very important question, and it is one of the main recommendations of the National Palliative Care Strategy in 2018 is to have a good system to collect information and data about what we provide. And the only way that we can tell if we're doing the right thing or not and to plan for the future is to collect this data. So currently it's a recommendation. I think we are taking some good steps in this direction, but we need to have more, I would say, integrated systems. So back to that integration, where we link data to each other, we can use it in real time and in, as early as possible, and also to, it's not just collecting the data, it's how to make use of it and how to put this in context to inform the right policy.
Yeah, I think the full patient or person journey is important. So as you say, linking across from beginning to end, of when a person arrives to the doctor to the very end, that's going to help inform policy-based decisions into the future as well.
I'm kind of surprised there isn't more research in this area on palliative care, end-of-life care.
Well, this is one of the reasons that Australia is number 2 in the world, because there is actually quite a lot.
Oh, there is, okay.
And the government, the federal government, has funded substantial funding, substantial research efforts. One of those is a thing called PEACOCK, which is the Palliative Care Outcomes Collaborative. It's based at the University of Wollongong, and they collect data from every palliative care service based on the effectiveness, looking at some clinical parameters. It's been going for well over 10 years, and something like 98% of the population is covered, but only in specialist palliative care. So we know nothing about what happens in aged care, and we don't know anything about what happens in primary care, where most of the death occurs.
Katrine has highlighted out-of-pocket costs for doctors, looking at travel, time, productivity. How do we begin to take that into consideration as well?
Well, I think any of us could answer that. I think that's a really good question, and there will be travel considerations, and so does that get implemented into a fee, maybe an excess fee? And this is driving to my point about out-of-pocket costs then to the individual, because it has to come back to somebody. So if it doesn't come back and it's not covered by the state or the government, then somebody will have to pay for it, so it could be the excess fee. So I guess that's where, I'm not 100% sure, but I think that's where the supplier can decide on their excess fee and then get their costs back that way, so that they're not out of pocket as well.
So it depends on the individual, it depends how frequently you are asked to be involved in end-of-life care. For most GPs, it's a handful of people per annum, and it's seen as a quality thing and not a cost thing, or it should be. There are people who will not do it on the basis that it's uneconomic. I might also put in a plug for nurse practitioners here. Nurse practitioners have a huge role to play in this, and they can be very expert and very, very effective at providing very good end-of-life care. We did a project in the Lockyer Valley, and it would not be feasible to keep it going if you were just relying on the nurse practitioner's Medicare rebate, because it would be an hour each way from base to patient for a 30-minute, 40-minute consultation, and transport is not covered, and the Medicare rebate has not increased since it was introduced 10 years ago. So they need a lot more help than they're getting. So that kind of thing does need a lot of attention. So there's out-of-pocket costs for the patients, out-of-pocket costs for the doctors, and you're really relying on the goodwill of the doctors.
That brings something like, normally when we look at things, we look, of course, at the patient at the center. We look also at the system, but it's also the provider's experience is important, and what they experience when they deliver that care in terms of any out-of-pocket expenses or other also implications when they deliver that service. So how satisfied they are with their role, what they are providing, are they well equipped with the knowledge, skills, etc. to deliver that role? It's something that we should not overlook.
I think it's interesting you raised that about the nurse practitioners. In fact, actually, we're currently just doing a study on that and the effect and the usage of nurse practitioners, and then how we can reduce reliance on long-term care services. Unfortunately, in Australia, we didn't have the data for it, so we're currently doing it in the US system. But hopefully, going forward, we can have a more population-based study on that question as well.
Is there any research as to how VAD actually affects the doctors who provide that service, and whether there are economic implications for that as well?
Yes, there has been a little that I've heard of. I haven't read it, but I heard it presented by one of the lawyers who wrote the legislation. And the short answer is that there are reports that it was a lot harder than they thought it was going to be to end a person's life under VAD.
Yeah, I just wondered whether there was any research about, whether the doctors then move themselves out of the system somehow, or not sure.
I'm not sure. I know that when you look at people's willingness to do it, or at least the willingness to think of it, then it's the proportion of doctors is, say, 60%. When it comes to their patient, then it drops, and when it's you that actually delivers it, it drops to under 20%. So, the action and the reality are two very different things.
Yeah, and I would imagine they would be. Another question for the panel: is there a provision in legislation for a person to pick a point in their illness to activate VAD? For example, when I can't eat or drink by myself, I'd like to access VAD.
No.
No? No,
it is purely on that you are enduring unbearable suffering, so that is a catch-all.
What about, this person also asks about declining cognition, as you your body starts to fail, your mind starts to fail as well. The position you were in a week ago mentally may not be the position you're in 7 days later. Is that taken into consideration, or are you working on how that person felt earlier?
My reading of it is in fact that, and I think there could be a number of people out there with cognitive decline who can access, because it's not been actually diagnosed. So people who are diagnosed may be excluded, but those who are not diagnosed at that point. So there is a little tiny grey area there, I think, of that as well. So yeah.
All right, yes, sorry, go on, Geoff.
Yes, you're right. It is. You have to make the assessment of capacity at the time that the request is made. So that's the only fixed time point, and there are two people who will do the asking or the assessing, and so long as the mental capacity is adequate at that time, then it can go ahead. And what happens after that doesn't come into it.
This question: what would you say to someone who might argue that VAD is accessible and equitable?
I think I would need further detail on that.
Yeah.
In terms of how, what do they mean? Is it across socio-economic group? Is it across regions? And that may be at an individual level. So we're concerned as health economists about the average person and the population level. So I would say we would have to be more clear about the percentages that you're saying have equitable access. How is it equitable? How is it funded? What's their ability to pay? And what's their actual need as well? Because healthcare should be based on needs.
That question could be asked, I think, of almost any aspect of healthcare in Australia,
but
depending where you are.
Yeah, but this is totally new, and it's worldwide even. You won't find many studies, especially about an economic evaluation or equity issues, etc. So we need more information. We need to research that, really.
Now, Kathy's asked, regarding underutilised palliative care services that are currently available but underused, how is uptake and utilisation of these being addressed? Is this something that, as a result of that, we will actually have to look at more closely?
They're not being underutilised.
Okay, so Kathy, they're not being underutilised.
They're flat out
Yep.
doing what they're doing now. What the problem is that the service isn't big enough for the need.
Yep.
Very big distinction. So they do very well with the patients that are in their care. There is absolutely no wriggle room for taking on extra work, and that's one of the big problems we've got. For example, the state government at the moment has provided extra funding for a program called SPACE, which is about getting specialist palliative care into aged care facilities to provide consulting services. And that's actually extending them considerably more than they've been extended before, but at least there's funding to provide that. Prior to that, aged care or people who didn't have cancer sometimes would not be referred because the service couldn't take it. That happened in our city under a previous specialist. It was one specialist for nearly 200,000 people, and they just couldn't do it. So they just took cancer patients.
So it's more a question of actually expanding palliative care services rather than looking at where they're underused.
And making expertise for basic palliative care universal. Then the need for specialist palliative care would not be as great.
Yeah.
Yeah, I think the answer is the workforce training. So again, we've one pot of money and resource allocation. How much more can it be expanded? But people can be retrained or they can be upskilled in this area.
Yeah, but I would say with this underutilization, it depends on the setting. So if you look at the services like home provided at home, most of the utilization is for services provided at hospital or aged care facilities. But when you look at the services provided at home, they're way much lower utilization. So the workforce should be, I'd say, the same. It's just people are not aware that these services are there. And one of the issues, like 50% or 70% of patients express that they want to die at home. But what we see right now is that the majority of patients, they don't die at home. And they don't know, it seems that there is a lack of awareness that there are services that could be provided at home, or there is lack of coordination, so those patients do not really, put in touch with the person who can help them receive care at home, for example.
Or lack of funding, because the services themselves, the domiciliary nursing services, can only provide work for which they're funded, and if it's not 24/7, then they can't do it.
Another question, how much have economic considerations been included in the legislation? When it was being argued, how often did money come up as an issue?
To be honest, from my viewpoint, not a lot. I hadn't heard too much. I mean, obviously I've heard about the legislation from the legal perspective and had an interest in that way, but not from an economic perspective. So when I was contacted I was actually asked to comment on some of the legality. I said, well, that's not my field, but we can bring in economics here, and that's what opened up the UQ, or that's what opened my discussion on it in the UQ contact article that we had with Geoff and others. So I feel that more could be done in including economic considerations, not just from a cost. It's not just, as we say, and without having to repeat, it's not from a cost perspective, but from a systems perspective.
Yeah, we have talked about the squeamishness of people to actually talk about this, but it's vital, as we found this afternoon, to include economics as a part of healthcare, to improve services, not just to say, well, I think people get scared it's going to be a slash and burn sort of effect to it, but not necessarily at all.
Yeah, absolutely, and I hope that today's discussion may have helped highlight, understand where we're coming from, that we work with others in the system, the physicians, the gerontologists, any healthcare professionals. We're all in interdisciplinary teams, and that's where we work, and that's where we're coming from. So we're not about slashing budgets and cutting costs. We're about having good, cost-effective care for everybody.
Yeah. What are the life insurance implications for those who undertake VAD? This is interesting. I don't know how it works anywhere else in the world either. Yeah.
I don't know.
No, that is a darn fine question, and we will try to
be confirmed.
It could be, actually. It may not have terribly much implication because the law says that if you die by VAD, then you mustn't put VAD on the death certificate. You die of cancer, you die of motor neurone disease.
Yeah, and once again, as we've heard, it's people who are at the very end of life. It's a terminal condition. There are so many things that have to be taken into consideration that doctors have to address, that this person was not, that they weren't going to, get out of whatever condition they've got. There was not going to be a turnaround in their condition. So
I think if they separated VAD out and it was called a cause of death, well then it may be different. But the legislation is very clear about that.
Another question. I'd expect there are a lot of qualitative benefits and considerations of any paths patients take in this stage of life. How do we capture this meaningfully in economic evaluations?
Sorry, could you just repeat that?
Yep. I'd expect there are a lot of qualitative benefits and considerations of any paths patients take in this stage of life. Yeah. So how can we capture this?
Yeah, sure. And I think Haitham would be quite familiar with this as well in terms of quality of life. And I guess that's where they're driving for the quality aspect and, how can we have a good cost-effective treatment, which would be cost per quality adjusted life year, for example. So it wouldn't be just about a life saved or a few days averted of life, it would be quality of life. And that's where the economic evaluation can be quite beneficial in trying to put a value on that. And if it's impossible to put a monetary value, at least have an effectiveness value in terms of quality adjusted life year.
Yeah, but qualitative research now is finding its way into health economics because we need to understand what patients value, what their preferences are. So typically we compare costs and effects most of the time are expressed in either life years gained or quality of life, but there are other dimensions of value that patients may consider, and the only way to consider this is by engaging with patients and healthcare providers, understanding what they value, and then trying to put a value for this and include this in the considerations of when we do any economic evaluation.
How might a decision to, and this is a question of coercion, how can we know that access to VAD is completely free from coercion, especially when social conditions might limit someone's option to quality care, access to NDIS, location again, as we've said. Is it ever possible to be totally free of coercion, even if that person coercing is yourself?
I don't know that you can ever answer that properly. Simply because you're not there at the time. You are only presented with what you've got, what's in front of you. You can get hints of coercion when people are pushed along by their spouse to come and see the doctor, for example. But we're talking about a very, very specific situation, and I don't know that can be answered really.
I think it is a fear though as well of older people or people who work with older people, and it has been mentioned to me also before today that it's a fear that some younger may coerce older or maybe just even cognitive declined, regardless of age, into decisions, just similarly like they may have made decisions about handing over a house, for example. Now it may become this. I don't know the numbers on this, and as you say, it's all individual, but it's something that people are fearful of. So I think information might again help the public to understand this better.
Yeah,
I can say that the legislation prohibits medical and health practitioners from raising it. It's actually got to come from the patient themselves.
Prognosis is difficult and subjective to estimate. It seems the legislation's vague on how likely it is someone will live less than 12 months, meaning large errors in estimating survival might occur. So once again, this goes back to that fear of somebody being maybe pushed or thinking they've got less time to live than they may have. So how can we protect against large errors in estimating survival?
How are you going to find out?
You just got to keep living until. But this is an interesting question though. Like how do we know? Because some people can get told, oh, you know, you've got 6 months, and 2 years later they're still going, or some people can be told you've got 6 months and 3 weeks later they're gone.
You make some spectacular errors with prognosis, and so it's usually an error to put a number on it. You can give a range, so days to weeks, weeks to months.
Yeah. I mean, we include uncertainty all the time into the economic evaluation models, and like that have a range of a sensitivity or uncertainty involved, so that the average is not exactly the number. It's in between.
The truth is somewhere in between.
It's somewhere in between, and that's at population level. At an individual level, it may be more tricky if you have defined it. You have 2 weeks when in fact it could have been 6 months. That's again that's something that comes into the person's decision-making process.
And once again, time is one thing, quality of life is another thing.
Yes.
So another consideration that must be brought in for hopefully before someone.
It's probably the first one that should be brought in.
Yes.
So the whole point of good end-of-life care is to maximise quality of life. And that doesn't necessarily mean just controlling symptoms. It controls things like, or tries to control things like boredom, hopelessness, existential distress and so on. All of those things, if you're doing your job well, will at least be raised and solutions attempted to be found. And that's hard work. It takes a lot of effort to do that, but if you do it well, it's very rewarding.
There was another study done about people's willingness to pay for end-of-life care, and they focus back on pain management and investment and better pain management. And if they have sort of a certainty that there would be better pain management into the future, then they may be less likely to worry about those last days of life. So perhaps, again, going back to the preventative stages of investment, that may help as well.
Yeah. A lot of these questions seem to revolve around this being abused as a system by people who are, you know, the relatives, family, whatever, of the person who is getting towards the end of their life. With the legislation, with the laws, is that a valid concern that people can be coerced into making a decision, or are there enough hoops to?
It could happen, but I don't know that the legislation can do anything to stop it because it happens behind closed doors at home or when visitors visit. And it's not going to be witnessed by anyone who's got any authority. So the best that they can do is to make sure that the health professionals themselves don't coerce, and they've done that, but that's about it.
And then on the flip side of that, how might an economic glance take into consideration effects on the family of someone who wants to access VAD, but they as family members disagree? You talked about the loss of work to care for someone, those kind of fiscal implications. Is this an important consideration that needs more research as well?
Yeah, definitely. There is a spillover, what we call on. So it's not just the quality of life of the patient, there is the quality of life of those who look after them. And it's not also the quality of life physically, emotionally, and also the costs they would incur out of pocket and other loss in productivity, etc. So looking at this dimension and having a societal perspective when we look at things is really important when we do any economic evaluation or consider the economic impact.
Including the value of the informal care is really important, and that's where the societal perspective comes in as well.
Yeah. Do we have any figures on that? How much care given by, how much it is worth, that care given by family members, for example, in at-home care, or even those who go into the nursing home and actually take care of their loved one on a regular basis, and a lot of people do that too.
It's quite extensive, and what's quite interesting, if you look at statistics across Australia in terms of residential care versus home care, in fact actually most people may avail of aged care funding through residential care, but it flips around when you go into Northern Territory, and that's mainly because of Indigenous groups and people who provide informal care at home. So that is a value. There is a huge value on that to society and the economy, but only in certain regions, in certain areas.
Yeah. It's interesting in itself, isn't it? How we look at that care, whether it is deemed to be something that we take into consideration economically, or whether we see it as just, well, some families do, some people within a family do, and others don't, and there might be good reasons for that, or not.
I've heard it said that if the volunteer workforce, the family caring workforce was removed, the country would go under.
Yep.
Because it's so much of it. The proportion of Australians who are a carer of someone who needs care is enormous. Something like 1 in 4, 1 in 3, or something like that.
Yeah, I think that's quite common, and it comes from an altruistic point of view as well. People want to care for their family, and I'm not sure what the proportion is that are obliged to care because the system isn't there. It might be a want rather than a driven need, but it does help. It does help the system, and that's the issue, particularly with the ageing demographics changing, the move towards less people being available to do the informal care. Hence the need for now to invest in the training of the workforce.
Those who were historically the carers are now at work.
Exactly.
Yes.
Paid work. So someone's got to do it, and it becomes a societal cost.
So it puts an interesting twist into the economic evaluation, actually, because generally we look at the cost of, we put it on the cost side, the cost to the informal carer. In fact, if a person can go back to work, is that seen as a benefit to them? So I think there's a very interesting piece of research there that hasn't been done yet, and that maybe might come out in the future.
Absolutely.
What would you say to someone who suggests that a new social norm might arise whereby legalising VAD could increase the number of suicides amongst those people who are not legally approved for VAD? Is there any evidence that people will take their own life if
I read in the government's response to the consulting that something like 1 every 6 days there was a suicide of a terminally ill person. Now, I honestly have got no idea how they got that figure. How could you possibly measure that? So I suspect it's anecdotal, I just think that it's an impossible thing to quantify. Will it happen? It probably does. How often? Who knows?
And there are a lot of comments coming through talking about the different states and different rules and budgets as well. We know Queensland's the 5th state to come into play in this space, so there are going to be differences by location. Do we know about those different states? Have they had vastly different results in that legislation? Are there differing levels of take-up in different states, for example? Do we know enough yet to know?
I don't think we do. Victoria's really the only one with any sort of track record. And I believe that around 120 people take it up each year. I don't know anything about the costs involved. The processes, I know that the Queensland legislation had a close look at what happened in Victoria, and they have made some modifications based on the experience of the Victorian legislation.
So is this about cooperation as well between the states, sharing that information, and researchers obviously share information, but and then getting to a better understanding as a nation as to where we are with this, how it operates, and how it can better become an equitable situation around Australia.
I think that could become quite enlightening to see differences in variation in care and also the costs involved, because I'm sure they will vary, particularly for the out-of-pocket costs, depending on what state. Compared, say, to the US, there aren't that many states here, so to do a between-state study is a bit tricky, and it might be something that somebody can take up elsewhere.
What about other places in the world that have VAD? Is the research there easily available?
I think there's been more studies done in, say, Switzerland, the Netherlands, the US on the economic implications, and that's where I would get a lot of my figures from about the end of life. So they're there a long time, but still the research is quite small. There aren't that many studies done. Yes, it's an area maybe that not many want to research.
And Jasmine asks, are you aware of any country or health system in the world where you perceive end-of-life, palliative care and VAD is actually being managed well and evaluated well? Well, palliative care is apparently pretty good here, Geoff Mitchell, as you mentioned. Not enough of it, but...
Netherlands probably has had the longest experience with this, and my understanding is that the palliative care services did take a bit of a back seat, but they're getting the balance better. I know in Switzerland that palliative care is undervalued and underutilised. They will only pay for the last, I think it's 14 days of life. And Switzerland is a place where end of life is, voluntary end of dying, assisted dying is legal. I have actually visited Switzerland and spoken with palliative care people there, and they are quite distressed at they have to be very careful that they referred patients who have less than 14 days, otherwise they just go back to the ward, or they have a huge cost overrun which they've got to get somehow back to the system. It's not
and that
good.
goes back to timeframes being very difficult.
Timeframe's difficult, but also the nature of palliative care. If you think that palliative care is the last 14 days of life, you're mistaken. It's a very poor form of palliative care because the more extensive quality of life issues, the psychological and the existential issues can take months to resolve, and symptom management can take weeks to get really well under control. So 2 weeks is nothing.
All right. Well, we're at the end of our discussion today, but the question, if I can get a final statement from each of you, is voluntary assisted dying or VAD the solution to end-of-life care? Geoff Mitchell.
Okay. Well, I'll make my bias clear. I don't think it is. And it's law now, and I'm going to adhere to the law, but my job will be to make sure that all my patients are in a state where they're not suffering unbearably. And that's what I'll do to try to avoid that question ever having to come up.
Haitham.
I think we need to put patients at the heart of things. We need to consider their preferences, values, and we need to make sure they're as comfortable as possible when they reach that stage.
And Brenda.
I think voluntary assisted dying is part of the discussion perhaps nowadays of end-of-life care, but a wider discussion has to take in all of the other aspects as well.
Thank you so much to our panellists this afternoon, Brenda Gannon, Haitham Tuffaha and Geoff Mitchell, and thank you so much as well for being part of this today and for all your wonderful questions. And on behalf of the University of Queensland, thank you for being part of our discussion.